I seem to be, how many years? I've been here, like 3, 4. This is the 4th year, so it's great to be back again. Thank you all for coming. And thanks, Becky and Ingrid, for all the great work that they do organising this conference, and the state for backing it. It's nice to see everybody again. So I'm going to talk to you about breastfeeding and substance abuse. I have to look at that screen because I'm at that horrible age where your glasses won't work on both levels. And I refuse to get bifocals. So I'm going to talk to you about breastfeeding and substance abuse. Now, I just want to give you a little warning up front that I hope you're all sitting there thinking, oh, good, when I get back to my hospital, I'll have definitive answers on this. Because unfortunately, there's just no definitive answers at all on this. But what I hope to talk to you about is some of the sort of things that will make you think about how to do it. And I'm going to give you some guidelines, some ideas for guidance at the end. But really, it's kind of, the more you look into it in a way, the more complicated it gets. And there's a whole moral versus medicine aspect to it. So let's just have a go. We're going to talk a little bit about the mechanics of drugs getting into milk. Then we're going to talk about ethics and framing considerations, and then the current literature and some other recommendations. So many of you may know this already, but those of you who are not totally into the lactation scene may not be familiar with all of this. Medications and drugs, illicit or not, are all part of the same sort of family. So the same rules that govern how a medication might get into a mother's milk are the same things that affect illegal or illicit substances as well. So drugs enter the human milk by passive diffusion via the blood supply to the alveoli in the breast. And the presence in milk depends, just like with over-the-counter or prescribed medicines, things like the size of the molecule of the drug, the oral availability of the drug, the half-life, the fat solubility, the size of the molecule, so very little molecules, which an alcohol molecule is a very small molecule that gets into the milk very easily, and the big ones don't. We're not quite sure exactly what happens in the first 1 to 3 days. Some things do. But so, for example, insulin has too big a molecule to get into human milk. So, think on those terms. It doesn't matter how much insulin the mom's on. It's not going to get into the milk because the molecule's too big. So it's not like every single thing that mom takes all the time sort of sits there in the breast waiting to ambush the baby. There are things that govern what gets into the breast and into the milk. For example, in illicit drugs, cocaine has a low molecular weight and gets into breast milk very easily, whereas methadone, marijuana, and buprenorphine and heroin have higher weight and are less easily transferred into the milk. And things that are poorly absorbed via the gut are less likely to get into the milk. If you think about that, we may, some of these things you don't think about the mechanics all the time, but if it's something that mom cannot take orally because she's not going to absorb it, then obviously the baby's not going to be able to absorb it as well either. So anything that has a poor oral availability is less likely to get into the baby, both via the milk and via the baby's own gut. So, for example, buprenorphine has a very poor oral availability. And then there's the half-life. So any kind of drug which has a long half-life will stay in the system longer. So like we talk to moms about whether to take medications, if you want to take a cold medication, if you take a 24-hour long-lasting cold medication, that will definitely stay in your breast milk much longer than something that's a short medication that you clear easily from the system, and then once it's got out of your system, obviously it's not going to get to the baby anymore. So we think about that for all types of drugs, the duration of the half-life of the drug. And it's better to take a drug with a short half-life because there's less exposure. And then the classic sort of breastfeed and take the medication immediately afterwards is good for a good advice for drugs that you need to take. And then, that again, it's not waiting to ambush the baby. So when the drug's cleared the mother's system, such as general anesthesia, it's cleared the breast. If mom's up and walking around, she's not on general anesthesia. That medication's not sitting in her system anymore. So it's not going to suddenly put the baby to sleep because it's not there anymore. And I think we tend to forget these really basic, obvious principles on how these things work. But because of the passive diffusion, if the drug in the mother's system is at a high level, it becomes trapped in the breast because it doesn't get out because there's no diffusion out of the milk because there's a high level in the system to begin with. And then other factors, fat-soluble drugs can concentrate in the milk. Weak bases concentrate and acids are inhibited because milk is slightly more acidic than plasma. Highly protein-bound drugs pass poorly into the milk, so methadone is one that doesn't pass well because of the high protein binding. And highly charged molecules also pass poorly into breast milk. Now, obviously, it's a balance because some drugs will fall into one category and not another. So, for example, some drugs may have high protein binding, but they also have a really long half-life, like methadone. So it's not a precise science. And absolutely, the research is really, really scarce. Why would the research be scarce? It's not ethical. You can't start putting moms on cocaine and see what happens to the baby. So there's really very little research about this, and a lot of what has been done is kind of being done incidentally rather than on purpose, or it's been done in animal studies. Of course, don't forget the baby factors. Older babies who are eating solids or just have a better developed system are more able to excrete things more easily. They can metabolize the drugs easier than babies who are very young and the metabolism is still developing. Preemies are at higher risk, but of course, and this is the big thing that we always have to remember whenever we're talking about any kind of exposure or medication, the baby's problem with formula feeding is going to be higher if it's a preemie. And in general, it's a cost-benefit ratio. If you don't, we've kind of gotten used to that with cigarettes. We say, oh, well, it's better to breastfeed and smoke than it is to breastfeed, to smoke and not breastfeed. Because if you smoke and you don't breastfeed, there's two health risks there. So it's always a sort of benefit-risk ratio, and what is better to never breastfeed because you smoked some marijuana, or, to think of it in the same terms we've begun to think about smoking. So just to give you a little background on the prevalence of illicit drug use in the US right now, this is the most recent study that I could find, which was a big SAMHSA study from 2013 data. And they have that 9.4% of the US population over the age of 12 has used illicit drugs in the month prior to the survey. And the most common drug was marijuana. And we're going to talk about that. I know it's not illegal anymore, but the highest used drug was marijuana. And then, interestingly, looking at pregnant women, so obviously there's a lower rate in pregnant women than in overall, which shows that maybe pregnant women getting the message and trying to cut down or not use drugs during pregnancy. Because in the same age group of non-pregnant women, there was 11% drug use, but only 5% drug use in pregnant women overall. So that's kind of interesting. And then the other thing that I found very interesting about that is that among pregnant women, drug use is highest in your youngest population, which I suppose is self-evident, won't be. But it's worth thinking about, if you've got a drug problem, but you also have a real lot of young mothers, maybe the drug problem is related to the fact that they're young and they're more likely to be pregnant and taking drugs, whereas when you've got older women, they're less likely to take drugs. You can see that it's only 3% among women between 26 and 44 years old compared to 15% among pregnant teenagers, which obviously all kind of would add up in a clinical setting, but it's just an interesting thing to consider. And then, of course, and this is one of the big killers for all of us, it's not just usually drug use. If people are using drugs, it's very complicated. There's a reason people are using drugs. For all women, and you'll see, just look out for this as we go through these slides, because you'll see that quite often the guidelines say, nursing women shouldn't take this, but it's because parenting is applying to all women. It's regardless of whether they're nursing or not. Drug use impacts parenting skills, regardless of what the mother's, whether she's breastfeeding or not. And often they're using multiple substances and abusing alcohol. And then there's the potential HIV status for anyone that's using IV drugs and using needles. And HIV, obviously, is contraindicated in breastfeeding women in this country. And then other things that go along with it. So often women will have poor nutrition, mental health issues, and potential for complex issues around parenting, living circumstances, child protective services, and that kind of thing. So it's not just like, okay, if she's taking that drug, can she breastfeed? It's much more complicated than that. But according to the ABM, despite the myriad factors that may make breastfeeding a difficult choice for women with substance use disorders, drug-exposed infants who are at high risk for an array of medical, psychological, and developmental issues, as well as their mothers, stand to benefit significantly from breastfeeding. So I think, we all need to sort of take a look at ourselves, where we stand morally, ethically on this issue, acknowledge where we might stand, and then move forward. Things that spring to mind. I was in a hospital in Texas a couple of months ago, walking around, and the nurse said, "Oh, I don't let anyone who's using marijuana breastfeed." And I'm like, "Oh, why is that?" "Well, my son has a drug problem." And she just said it like straight out, so that's why I don't let them do it. And, that might be her take on it. That's like saying I wasn't breastfed, so I'm not going to encourage other people to breastfeed. I mean, you just really need to examine where you stand on it and acknowledge where you stand on it, and then think beyond that, whether that's the same message that you want to be giving to your patients. So as I said, it's very hard to study the impact of drugs in breast milk because there's very little research. There's almost zero evidence either way on outcomes of illicit drugs in breastfeeding infants, except for like these sort of horror stories, case studies, very little else. This is a really key thing that people sometimes forget. Most babies have been exposed to these substances in utero as well. So, when we look at, the breastfed and then, the baby had marijuana in its brain, well, we don't even have that level of data, but if we were to look at that, the baby's been exposed to marijuana during the period of development as a fetus too. So, take that out of the recording. It's really not, you don't know where that marijuana exposure is coming from, and ditto any other drug that they may be on. It's not necessarily because they're breastfeeding. It's going to be it could potentially be because of the exposure in utero. A lot of our policies are couched in very moralistic terms, using words like allow. We won't allow babies to breastfeed or moms to breastfeed. And then again, always remember that there's a risk-benefit ratio, and it's not all, they shouldn't breastfeed because they're on a certain drug. So where can I get definitive answers? You can't get definitive answers, but you can go to LactMed, which is a wonderful source of information. I hope you're familiar with LactMed already, but it does also have all the information on these illicit drugs. You do not have to copy that long HTTP down. You can go and Google LactMed when you get home and you'll find it. LactMed's a service of the National Institutes of Health. Tom Hale is a lovely guy and he has some lovely books, but LactMed is very, very up to date, and it presents you with all the evidence. And to the extent that the AAP no longer publishes a regular statement on medications and human milk like they used to, but they defer to LactMed because all that information is in LactMed. So that is the best source of drug information, there's no question. And I'm not saying that any other sources aren't good, but that is the most up-to-date. So definitely go to LactMed and Google all your needs for that. So again, without going into definitive stuff, but just talking around some of this, what about some of the specific drugs of abuse and breastfeeding? So cocaine's pretty bad. Cocaine's pretty bad. Babies are highly sensitive to cocaine because they haven't developed the enzyme that inactivates it, according to LactMed. LactMed will give you this kind of information too. It doesn't just sort of say, here's a study. It actually sort of summarizes the studies and keeps on updating the summaries. And there's been quite a few adverse outcomes monitored in breastfeeding babies who have been exposed to cocaine. So it's really not a very good thing. It gets into the breast milk at high levels, and babies can get intoxicated by it. Interesting to say, this is cool stuff. Cocaine should not be used, says LactMed, by nursing mothers or smoked by anyone in the vicinity of infants. But remember, of course, that no mothers are on permanent cocaine. So LactMed also says that an abstinence period of 24 hours has been suggested for women who occasionally use cocaine while breastfeeding, based on the fact that it's rapidly eliminated. You may not be going around saying that your moms on cocaine should breastfeed, but just realize that it does go out of the system. So, that's what LactMed said. Meth is also a problem that gets into breast milk and the serum. But this is the kind of recommendation that withholding breastfeeding for 24 to 48 hours after maternal use of meth has been recommended. But breastfeeding is generally discouraged in mothers who are actively abusing amphetamines. Meth is really a huge problem in some of the northern United States. I don't know what sort of problem it is here, but up in Montana and some of the northern, especially some of the Native American reservations I work with, meth is a huge problem, very debilitating, very problematic drug, very kind of common in those areas. And really, it's not a great thing to have that around babies. But this is the recommendation that one place came up with, that breastfeeding should be withheld for 48 hours after recreational meth use. And I think it's interesting that LactMed says It should not be used by nursing, that's my emphasis, by nursing mothers, because it may impair their judgment and childcare abilities. I would think it would impair everybody's judgment and childcare ability. So why, like Med, stuck that word in there by accident, I'm not sure. But, you know, just look out for this stuff. It's all over the place. And that's one example, and you will see some more. And of course, this is one of the cases where, you know, you do see these big scare stories, and it's almost sort of like those scare stories you get every so often by dehydration. You know, a baby dies because the mother couldn't produce enough breast milk, and it's all over the newspapers. But if we as lactation professionals look into what happened in those cases, there were many holes that those babies have fallen through and that they could have been rescued from. And this is somewhat similar, really. This is one of the... You'll see these things in the news every so often that, you know, the mother had used some street meth. The baby was found dead 8 hours afterwards. But it was a very small amount of breast milk that was actually ever taken in. And it's highly unlikely, if you read the case report, that was coming from the breast milk. There was something else going on here. But the mother was convicted of child endangerment. Although the actual question of whether it was meth in the breast milk that was the problem is really somewhat unlikely. Opioids, what sort of issues do you have around opioids here? Many. Opioids is like huge. You look at the news lately, everything, opioids. It's a iatrogenic issue. We created it ourselves by giving out all those lovely painkillers all those years, and now everybody just thinks they're wonderful and doesn't want to stop. And suddenly we've got this complete monster. And, you know, this comes in a range of forms. And again, there's some of the populations I work with in the north. Buprenorphine is actually the main drug of abuse. It's a huge, huge issue. And not much treatment either. So, you know, and it's difficult to spot sometimes because a lot of this is prescription. And so you don't know whether it's like people are getting it because they need it, people are getting it because the doctors are under pressure to give it, why, you know, how much is being used, how much is being shared, because you can get it on prescription, so are people sharing it with other people. But we do know that more than 25% of privately insured and more than 33% of Merewood enrolled women of childbearing age filled a prescription for an opioid in the study from the MMWR study each year between 2008 and 2012. So it's very, very common. That's, you know, a quarter to a third of your population. And those were the most commonly prescribed opioids. So it's extremely common. It's a huge thing. I don't know what level of kind of care you have in pregnancy here for this, but the standard is maintenance therapy of some kind, so that, you know, you can't detox from opiates in pregnancy because the baby will suffer too much. It's not. Don't think of it in those terms. You've got to. If moms start to try and stop taking opiates in pregnancy or opioids, their baby will go into withdrawal. It's very dangerous. And also, a couple of things that we've learned about that is that it's not. You can't just stop. I mean, you can't just stop. You get terrible withdrawal symptoms. So people aren't necessarily, or aren't really doing it for the high anymore by the time they're really addicted. The withdrawal symptoms are just horrendous, with vomiting and diarrhea and headaches and all those kinds of things. So people really find it difficult to withdraw, to stop. So if people say, I'm going to stop in pregnancy, the literature shows it doesn't work. People don't manage to stop. But what they do is they'll stop for a few days, they'll go into withdrawal, the baby will go into withdrawal, then they'll take something. So their levels are going like this all over the place. So what you need is a maintenance program which traditionally has been methadone, but also buprenorphine. And of course, we think more of this in terms of heroin addicts, like that, the really big stuff, but the same is true for all kinds of opioids and opiates. And it's kind of interesting, some of the populations I work with where they've got 30 to 40% opiate abuse during pregnancy, we're kind of glad they're not on heroin, and there's no heroin in that community. So it's like, so what we're going to do here, you know, we're going to sort of say everyone's got to stop using opiates, then some heroin dealer's going to come in. So it's really kind of a very fine balance between what's good, what's not good. It's not an easy thing to have a solution to. And it's going up. So it went up from 1.19 to 5.63 per 1,000 births between the years of 2000 to 2009. And if you Google it, it seems like every month there's a new report on opioids and use in pregnant women. Buprenorphine, I don't know how much you have around here, but in the communities I work with in Montana, it's the main opiate of abuse. It's got a high molecular weight and poor oral availability, so it's not easy to get into the milk. So actually this is being touted as one of the answers and one of the ways that we can give moms methadone maintenance during pregnancy. Methadone was always used, but now buprenorphine is coming in as something that's quite popular, and it seems to be sort of slightly better than methadone. And looking at buprenorphine in breastfeeding women, and that's another reason it's a good thing, because of course you put them on maintenance in pregnancy, you can't just sort of stop it when they've got the baby. It's not like it's going to go away. What are you going to do then? You have to think beyond the baby. But if they're on buprenorphine, then they actually can breastfeed fine, and in fact it's actually recommended in breastfeeding women. So because of its low levels of buprenorphine in breast milk, poor oral bioavailability in infants, and low drug concentrations found in the milk, in the serum and the urine of breastfed infants, its use is acceptable in nursing mothers. That's what LactMed says. And again, there have been studies that show that it not only is it helpful for women who breastfeed, but it could lessen NAS. Now, neonatal abstinence syndrome is what babies go through when they've been exposed to opiates in pregnancy. Opiates is the natural form of the drug, and opioids is the created form of the drug. So there kind of depends what kind you get, depending on which they are. But, but it's a bit sort of idealistic to say, oh, good, they're getting it through the breast milk, so their symptoms are less. We haven't really got any proof that the small amount they get through the breast milk makes any difference. But certainly it's not disadvantageous to those babies to be on, for the mothers to be on buprenorphine during the lactating period. And their NAS is lowered, and it may be because the mom's breastfeeding. It may have nothing to do with what's in the milk. It may be because mom and baby are together, they've gone skin to skin, they've done all that stuff, and the NAS is lowered. Because we do know that breastfeeding and skin to skin and rooming in lower NAS symptoms. We know that, and that's been researched. NAS is neonatal abstinence syndrome, when they scream and you score them, and if they get really bad, they have to go onto some kind of medication like morphine to control the baby's withdrawal symptoms. So we encourage methadone or buprenorphine-maintained women to breastfeed regardless of the dose. It's kind of interesting, and those of you who work with women who use these substances may have found they kind of find it frustrating themselves among each other that it doesn't really, there's no correlation between the dose of methadone that you get during pregnancy and how bad the baby's symptoms are when the baby's born. You would think that the less methadone you're on, the less withdrawal the baby goes through, but that's not actually the case. There is no correlation. So it's just a kind of interesting thing. They think, people think, well, it's best to be on a low dose, but it actually doesn't impact the baby. And similarly with breastfeeding, there's no cutoff. Well, if you're on a high dose of this, you can't breastfeed. They recommend it regardless of the dose. And so methadone, which is still probably the most commonly used drug in treatment programs, has very little getting into the milk. And it's recommended also, and methadone's been recommended by the AAP for a long time in breastfeeding women since about 2004. This is interesting because I was actually working as an IBCLC when the AAP changed its mind on methadone, and just to go through firsthand all the sort of, the nurses said, no, well, we don't really care what the AAP says. We're not going to let them breastfeed on methadone, not just the nurses, the doctors in the NICU. And the argument was always, there was all sorts of different things that they could be on. These women shouldn't be breastfeeding. I heard that commonly. These women shouldn't be breastfeeding if they're on methadone. And it was really, really hard to get the change in practice. People wouldn't pay any attention to what the AAP said. They just didn't think that these women should be breastfeeding. So, but it is recommended. And there we have it, that the protocol from ABM actually talks about the lack of support from the healthcare community and misinformation about dangers of breastfeeding while on methadone therapy are significant modifiable barriers to breastfeeding success in these women. But they actually encourage us as healthcare providers to provide robust support for people. And I remember, working with my patient population, because in our hospital in Boston, when women are on methadone and the baby's got NAS, they go from the newborn unit to the pediatric inpatient unit. Not easy for moms. They had to go out every day because they only gave them one pill at a time, and then come back to the hospital, and there definitely was not encouragement on this, especially on the pediatric unit, for them to breastfeed. And we had to do a lot of work with them because it was really hard to get people to accept it. And then I think it's interesting that back in 2004, this is kind of what was said at the time. While not recommended by the AAP, some methadone programs allow breastfeeding. Breastfeeding may be allowed if there is close supervision, and they use the word allowed twice in that sentence. And the minute anyone tells me that something's not allowed, I mean, they've had it with me. I'm like, my first reaction is, okay, how can I get around that? So, it doesn't matter what they're talking to me about, really. So just be aware how it sounds. Women will go home with these babies. You will not be in their home. You're not going to say to them when they're sitting at home 3 days later, you're not allowed to breastfeed. And people in cultures that, are isolated and have drug problems are sometimes from cultures that breastfeed in rural communities. There's an awful lot of rural communities where meth and some of these drugs are a huge problem. They're way away from you, and they're not going to sort of say, they might say, well, that doctor told me I'm not allowed to breastfeed, so I'm just going to do it. But, you're not there. You're not going to be there vigilantly. So think of how this says. And, this is only in 2004 that they were saying this, and now we've really changed our tune. So things have changed a lot. And the Canadians are always a lot more liberal than us, so they've said that, basically you can breastfeed on any kind of opiate you like, and that's the Society of OB&GYN of Canada. Maternal opiate use is considered compatible with breastfeeding. So again, where are we looking at what gets into the milk, and where are we looking at the rest? So here's a lovely subject for controversy: marijuana. Now it's legal, so is it going to be okay now then? Because it's legal. So, who cares about the medicine? It's legal. And this is another really hot topic. So little is known about the adverse effects of postnatal cannabis through breastfeeding because of a lack of studies in lactating women. We do know that the THC, the drug, gets into human milk. It's fat soluble. It gets concentrated in the milk and higher than in the plasma. It definitely metabolizes. Infants absorb it and metabolize it. It's pressed out with meconium. And it can be stored in fat tissues for several months, and it has a long half-life. So your babies are definitely getting marijuana. There's no question. And they have been having it since the mom's been smoking during pregnancy as well. So there's a lot going on there. And, of course, because it sticks around so long, you can't tell when you test those moms whether they had marijuana yesterday or they had it a month ago, because the levels it's absorbed in the fat and the levels are high, and you can't tell how recently the marijuana dose was. So it's positive in the mother's urine for 2 to 3 weeks. So you can't even tell. Occasional from, like, mom says, I only did that last night because I went to a party. You can't tell if that's true or if she's been doing it 10 times a day. I mean, it's really difficult to distinguish. We do not know really what the effect of THC is on development in infants. There's no real data in human infants evaluating neurodevelopmental outcomes. There is data from rats. The stuff that you see quoted as being impactful on the brain is often the rat. There are some rat studies. And the other thing to note is that the potency of marijuana has really gone up since the 1980s from 3% to 12%. So they're getting a higher dose as well. So some studies have concluded that this is quoting one that this is from a specific study, these quotes. So this guy who wrote this, or woman, whoever they are, said that some studies conclude that THC could decrease motor development of the child at 1 year of age. Therefore, cannabis use and abuse of other drugs like alcohol, tobacco, or cocaine must be contraindicated in breastfeeding. So don't believe everything you see in the medical literature. Like, how can somebody stick tobacco and cocaine into the sentence and say, well, contraindicate everything? And that's not what everyone else is saying. So, but that particular study recommended that. And ABM just, if you read their statement, God love them, they've tried really hard to come down. But it's very, very difficult, and it's not very definitive on anything. And again, we're talking about laws. So what's laws got to do with medicine? But anyway, as laws shift and marijuana use becomes even more common in some areas, it becomes increasingly important to carefully weigh the risks of initiation and continuation of breastfeeding while using marijuana, with the risks of not breastfeeding, while also considering the wide range of occasional to regular, medical to heavy exposure. So no one has a clue, basically. No one has a clue, as they say. And basic recommendations on marijuana use and concurrent breastfeeding from a purely legal standpoint becomes inherently complex. Well, it should have been anyway. It shouldn't really have that much to do with legality, and impossible to apply uniformly. But they think that we should tell people to cut it down, which is probably a really good plan, not whether anyone's actually thought that they didn't have to say that to begin with. I mean, no one's going out there saying, oh, we think you should smoke a bit more marijuana because you're having a baby. LactMed, they kind of beat about the bush as well, really. Then basically it just says, we don't know either. We don't know either. Studies were inadequate to rule out all long-term harm because they can't even really figure out what happens. And avoid, again, here we go. Marijuana use should be minimized or avoided by nursing mothers because it may impair their judgment and childcare abilities. I mean, and if we're not nursing, your judgment's fine. Like, is it the combination of marijuana use and nursing that makes you... But they are more liberal. They then go on to say that because breastfeeding can mitigate some of the effects of smoking and little evidence of serious infant harm has been seen, it appears preferable to encourage mothers who use marijuana to continue breastfeeding and reducing or abstaining from marijuana use while minimizing infant exposure to marijuana smoke. So actually, LactMed doesn't say you should stop at all. I reviewed a policy last week for a hospital in Alaska, and it's always really hard to kind of know what you're supposed to say when people send you these things. And they had if you use marijuana more than 4 times a week, we recommend you don't breastfeed. Okay, but where are you getting this 4 from? I mean, 2, 10. It's like you just pick these numbers. There's no data to show that 4 times a week's any less or more safe than 5 or 3. So if we want to get really into controversy, what about alcohol? So apparently, minute. So we all drink, right? But we don't all drink. Many of you may not drink, but I drink. Lots of doctors drink. Lots of nurses drink. So we're all familiar with drink. We might not all be going around using cocaine, but we're all likely to be using alcohol. So we don't think alcohol's that bad. So despite the fact that, in those other drugs, we haven't seen any changes at all in the babies, and we're still saying they shouldn't be doing it, we're saying here that minute behavioral changes in infants exposed to alcohol have been reported, but the literature is contradictory, and any long-term consequence is yet unknown, but occasional drinking while breastfeeding has not been convincingly shown to adversely affect nursing infants. I think you could use that phrase, has not been convincingly shown to adversely affect nursing infants for most of these drugs. But, with alcohol, we kind of feel a bit okay about it. And they say that in conclusion, special recommendations aimed at lactating women are not warranted. Instead, lactating women should simply follow standard recommendations on alcohol consumption. Well, there you go. You're all right, because we all do it, so we're not going to worry about it. And it goes on. But actually, alcohol does actually do some stuff. It inhibits your milk ejection reflex. It decreases milk supply, and it definitely gets into the milk very easily. So it isn't that black and white about alcohol either, no more so than anything else. But I just think you can see, and you go off and look at these things in a different light now, and you start to read these recommendations. We're a lot more lenient and liberal about alcohol than we are about other stuff that most of us may be using one and not using another. So where do you start with all of this? So ABM, sort of as a general guideline, says that, and again, I'm not debunking this, but there are huge issues with this stuff. So encourage women under the following circumstances to breastfeed their babies: women who are engaged in substance abuse treatment, maternal consent to discuss progress in treatment and plans for postpartum treatment with the substance abuse treatment counselor, and the counselor recommends that they breastfeed. It's good to talk to people's counselors. It's really good, actually, to talk to people's counselors because they know these people better than you do. And they know the moms who, they sort of think, this mom's really making a go of this. She may have had a couple of lapses, but there were a couple of lapses, and they know these people, and they're going to go and see them afterwards, and they are in touch with them, and they feel they have some kind of reliable sense, as opposed to, a mom who shows up 8.5 months pregnant and swears she never took anything, and she's got all sorts of positive tests. So it's really worth connecting with the counselors in many ways. And one of the most rewarding things I did when I worked in lactation at Boston Medical Center was to sit down with, we do the methadone maintenance program for the whole city of Boston. Like any woman who's on heroin in pregnancy and goes to counseling and gets methadone, those women have their babies at our hospital. So we have a good relationship with the counseling team. And it was just really interesting. They were just really pleased that I went to begin with. Like, it was just really nice that we showed up. And now we have some great programs going on at Boston Medical for these women, led by obstetricians, which are really very, very strong. Project Respect. And one of their terms, one of their sort of precepts is that everyone has the right to establish a milk supply. So we're going to talk to them in pregnancy as if they're going to breastfeed. We're not going to say you can't do it, and then we're going to sort of outline what we think would be good guidance. So basically, if moms are in that kind of a program and you have a good handle on them, you know, I think what motivates many of us who do this specific kind of work is that, in my view, there's no better time in a woman's life that you're likely to make a change. You know, she sees that baby. She wants at that moment never to do drugs again. I mean, there's no question. So imagine if you can help her to do that. And those of you who are cynics and work with people forever and say they don't change, maybe they don't, but a few of them will. And it's extremely, you know, positive time to do that, because the other, you know, at the same point in time is a really bad time to go downhill. You know, you talk about the life course trajectory, and you get to these sort of critical points, and as you're going up, it can make you keep going up, or it can make you go down. And birth is definitely a critical point in that. So you really want to consider, like, what support services you can give to people, and talk to the counsellors and connect with people about this. And again, if they plan to continue in abuse treatment, abstaining. Now, 90 days is just, like, guys, that's just made up. You know, 90 days, what does that reflect? Our sense of reliability that a mother's going to do something, maybe. It doesn't reflect medicine. It doesn't reflect the fact that maybe she had, like, cocaine, you know, a month ago, and that's still in the milk. It's not in the milk a month later. So the 90 days is just a sort of, okay, we think if we say 90 days, then, you know, you'll be okay. You'll keep doing this. So it's really not a very good thing. But, you know, this is all making sort of sense. Except how many people who are using drugs are doing all these things? If they're doing all these things, I don't know what kind of resourced communities you live in or work in, but the communities that I work in, and I'll disclose, I mean, it's with Indian Health Service, but I'm not saying that it's specific to the Indian Health Service. It's just that that's the communities that I work with in this. I worked as I was a consultant in the Montana area for this for a long time, and it all came up because of Baby Friendly, because we had a hospital in the north there that everyone was breastfeeding, and that was the one that we had 50% of drug use in the pregnant population. So the prenatal people were coming to me and saying, what are we supposed to tell these moms? What are we supposed to say? They all want to breastfeed. It was the only hospital where, I mean, the math wasn't done right, but we had more than 100% breastfeeding rate. Because all the women who were supposed to have been excluded from the denominator, they kept breastfeeding. So we took out all the ineligibles, but when we counted up, that we had so many people breastfeeding. And so these women in this particular setting were breastfeeding on all sorts of drugs, and there was no resources, none of this stuff for anybody. So it's a huge sort of moral dilemma. They didn't have any of these treatment programs at all. So those women were not supposed to breastfeed because they weren't engaged in substance abuse treatment, because we weren't providing anything for them. They failed to provide consent for contact with a counselor. We didn't have any counselors there. They weren't engaged in prenatal care. This is a really interesting myth, or actually we have to look into what level of myth it is. A lot of the time you will hear, and we certainly heard this in some of the hospitals I work with, well, if we test in pregnancy for drugs and then they find out we do that, they won't come for prenatal care. So we actually examined to see what rate of women came for prenatal care and what rate of women didn't come from prenatal care. And we did have still a bunch of women who were using drugs who were getting their prenatal care. But, you know, we haven't looked to see. It's the providers that were saying that. I don't buy it. Really what was happening is we weren't providing them with anything. So you come, you test positive. Oh, it's very nice. Keep taking your illegal buprenorphine because we don't have anything to give you. So, you know, it's what we do for them rather than whether they, so if we give them an open, you know, door and of course in a small community it's really difficult because everyone knows each other, including the doctors and nurses and families. So you have all those complexities of confidentiality or just people not even wanting to admit to it. And then, of course, they say these are all the obvious things that you shouldn't breastfeed on. Interesting chronic alcohol use, whereas that other bit said, you know, if we're using alcohol, it's all right. So actually at the IHS, and I'm very proud to work with the IHS, and I'm working with them again now. I just got a new contract, and I love working with them, and I love working with the tribal hospitals that I've worked with so much in Oklahoma. But we did actually have to tackle this head on, and we actually came up with some guidelines. Now, this is all being taped, so I won't go into the fact that no one knows what these guidelines are right now. But we came up with these, and we had them rubber stamped, and they are okay. They're probably not out there for anyone to have, but if anyone needs them, you can ask me, and I have had them rubber stamped. So breastfeeding and illicit drug use guidelines. The point isn't for you guys to go home and say, oh, we're going to do what IHS, Indian Health Service, IHS, we're going to do what they say. The point of what this is that you have to look at your population, whether that's in your clinic, your tribe, your city, and you have to say, okay, what works for these people? Because it's no good sort of making, as you can see, all those recommendations, there's a general trend, I don't do cocaine, don't breastfeed on meth. But then, you know, if people are going to do that anyway, in fact, when we introduced these guidelines at one hospital, the nurses actually said that they wanted to put in, they stood up and said, we have to support our mothers, whatever they choose to do, and they're all choosing to breastfeed. So we want a caveat in here saying, this is what we recommend, but I'm your nurse and I will support whatever you want to do. I mean, it's a very refreshing perspective, frankly, when you think of what else the community's up against. Anyway, we came up with this stuff that we looked at. We had this, sent this out to people beyond IHS. We used some of our physicians in IHS and our nursing people. So we said that we decided that based on the evidence that the drugs that are considered really incompatible with breastfeeding were cocaine, meth and heroin. And that's because not so much that the heroin is going to do anything, but that people on heroin just can't get it together to do anything really. So infants are at serious risk of adverse outcomes if the mothers use these substances and breastfeed. And of course, you've also got the complexity of, you know, mandatory reporting. I mean, this is not an isolated thing. If people are using heroin, hopefully they're going to get reported and someone else is going to step in and decide whether this baby's safe at all. And then drugs, we said that on the other extreme, drugs that are approved by the AAP, so we said methadone, because that's actually the only one that the AAP recommends. Even though the language around buprenorphine is very positive, they have at the end this long list of caveats. They can breastfeed on buprenorphine if, and then they have to be in all those other categories. Well, the women in our hospitals are not in all those other categories. They're not getting counseling. They're not going for treatment. They're not seeing substance abuse programs. So, you know, but the buprenorphine in the milk still isn't going to kill the baby, whether they're not, they're doing that. So we had to sort of look at that in that light. So we came down with this language that drugs where there's no definitive evidence to discontinue breastfeeding include buprenorphine, marijuana, alcohol, benzodiazepine, but babies should be monitored for apnea, and prescription pain pills. So we didn't say, oh, you can breastfeed, but we really left it for the clinicians. And of course, this is framed with policy. This is the guideline, but then there's policy to go on it. And we really left it with the clinicians to say, you know, okay, in this case, this mother's, you know, only taking buprenorphine. I've been seeing it in her pregnancy. I know she's okay. But so the clinicians will need to take these. So Alison, when you take pictures of this, don't go home and say that I said it. I mean, this is within the context of, you know, a clinical decision. And we've had to emphasize that as we've introduced these things across the system. And then the best practice guidelines say that, you know, just to caveat again, that where there's very little research or evidence on which to base clinical practice, clinicians should assess each situation on a case-by-case basis, taking into consideration, for example, the amount of the drug used, the mother's individual circumstances, available support, treatment plan, and access to care. Because you know what? Those women may not have a counselor, but they may have grandma at home, and everyone knows that family, and they know that grandma's looking after that mom and baby. So it isn't always going to fit into a traditional model, but in certain communities and certain areas, there are other models that might be helpful and supportive as well. And then, of course, follow-up. If you're going to do all that, you need follow-up. And the Indian Health Service has a wonderful system of follow-up. They have all the hospitals in the federal system. You guys have public health nurses as well in the tribal system, right? Yeah. So I think all the tribes as well. I think so. The tribal health. Do you have public health nurses in the community at Chickasaw? You don't? You're getting some, yeah. Every federal Indian Health Service hospital has public health nurses / community health nurses, and most of the tribal ones do too, who go out into the community and see moms at home after the baby's been born. And so they get extra training, and they are obviously going to follow up any baby in the home that is exposed to drugs during pregnancy. And hospital discharge should be delayed for approximately 72 hours. We put that in because we knew ours weren't being held that long. A lot of babies stay a lot longer than that, but that was to counteract. And again, this is why it's specific to our system. They were being sent home at 48 hours before they'd even peaked with their NAS symptoms. So we shoved that in because it's not realistic in the Indian Health Service to keep these babies for 2 weeks. I'm sorry, there's no money. We're not going to do it for 2 weeks. So you can't say you have to keep them for 2 weeks, and we know that they're not going to keep them for 2 weeks. So we pushed it out to 72 hours, and that's what we recommended, that at least they should have gone into some kind of withdrawal. And then, of course, if they're in flagrant withdrawal, you're not going to send them home, but at least you should catch them if they stay there for 72 hours. And again, they should be seen. And this is something that is definitely not just the Indian Health Service. There are millions of babies out there that are not being seen within what the AAP recommends, 24 to 48 hours. So discharge is just not being seen, and they need to be for all sorts of reasons, including the drug stuff. And then, we recommend that they're referred to lactation consultants or support in the field and followed closely. They should have follow-up with weight gain and growth established and made and a general assessment, and make a referral to public health or community health nursing. And relapses should be, prompt reevaluation of whether it's safe for that dyad. So, in conclusion, the science is far from perfect. Enforcement is not easy. Clinical judgment and consistency are important. If you decide that you're going to have this policy, you need to have your nurses or your doctors make sure that everyone's on the same page. Methadone's allowed. There's no good some nurses going around saying, well, we don't want you to do it, though. Create a policy that's realistic to your situation and doesn't come up with random numbers about 7, 10 out of the air. Avoid confusing a moral approach with a medical approach. At least be aware of what you're doing. And, acknowledge that many communities deal with unprecedented rates of substance abuse, and known strategies are really scarce. So, thank you.